Hello, my name is Jose Austine, and I'll be presenting our research study titled Clinical and Laboratory Profile in Confirmed versus Suspected Septic Arthritis Patients and its Relevance in Decision Making. Newman described three groups based on the isolation of microorganisms from the synovial fluid. A is when the organism was isolated from the synovial fluid of the involved joint, B when organism was isolated from elsewhere, and C when there was no organism isolated, but the histological and radiological evidence of infection suggested it to be infection. The published literature lacks studies comparing clinical and laboratory features between synovial fluid culture positive and negative adult onset septic arthritis patients. So we wanted to compare the differences in patient demography, clinical features, and laboratory parameters between confirmed and suspected septic arthritis in an adult Indian population. We also wanted to evaluate the risk factors associated with adult onset septic arthritis. This was a descriptive study carried out at a tertiary care referral center. We included patients who were 18 years or more in age presenting to the emergency medical services who were screened for the following criteria. The patients meeting criteria 1 with or without 2 were included in the study and subjected to arthrocentesis and synovial fluid analysis under aseptic precautions. We excluded patients with prosthetic joint infections and patients with history of acute trauma with open joint injuries. Our sample size was 35. The synovial fluid sample was collected in a sterile container and transported to microbiology and biochemistry within 2 hours, and it was done as per the standard operating protocols. Based on the report of synovial fluid analysis, the patients were divided into 2 groups, that is synovial fluid culture positive or Newman A, which is confirmed, and synovial fluid culture negative, which is Newman B and C, which is suspected. All patients underwent joint debridement and lavage. Preoperatively, we took their blood samples. Intraoperatively, the synovial fluid exudate was taken for culture and histopathology, and postoperatively, the patients received antibiotic as per standard hospital protocols. So we had 35 patients available for final evaluation. This comprised of 17 patients belonging to Newman A and 18 patients who were part of Newman B or C, that is suspected. The median age for the study population was 15 years, with a fair majority being males in both study groups. The knee joint was most frequently involved, with right being more commonly affected as against left in both the groups. One instance of bilateral knee involvement was noted in group B and C. Another patient with polyarticular involvement had culture positive septic arthritis of the knee and wrist. The mean duration of hospital stay was 18 days. No significant difference was noted between the 2 groups with regard to the clinical profile. Pain was the most common presenting symptom, followed by swelling around the joint. Fever was noted in only 22% of cases. 4 patients in Newman B and C and 3 in Newman A had discharging wound near the joint. 6 patients in our study group were either on or had received antibiotic treatment prior to synovial fluid culture or joint lavage. With regard to biochemical profile, no significant difference was noted between the groups. The synovial fluid gram stain was positive in only 5 cases after aspiration, 3 of which subsequently grew a microorganism. Most common organism was Staph aureus, with Pseudomonas being grown in 3 cases. All patients in whom gram-negative organism were isolated were immunocompromised. CKD and diabetes were the most common existing comorbidities. So in spite of treatment, septic arthritis continues to be associated with significant morbidity and mortality. In our study, no significant difference in the demography, clinical presentation, and biochemical profile between the 2 groups was noted. These findings were similar to 2 other prospective studies in the Caucasian population conducted by Gupta and Madruga. The reason for early age of presentation in our population subset necessitates further investigation. Although pain and swelling was a constant feature, fever and acute phase reactants were unreliable, and similar findings were reported by Gupta et al. Our study excluded patients with prosthetic joint infection because of our observation that they tend to skew the data from native joint infections. These were our limitations. So in conclusion, confirmed and suspected cases of septic arthritis in adults exhibit similar demography, clinical features, and laboratory parameters at presentation. The management should be based on sound clinical judgment in the event of failure to culture microorganism, and a constellation of factors must be considered and not just a single criteria. Thank you.